I take them.
Fertility Doc's uncensored site on all things fertility doctors around America. Conceive or just planning, you're here to guide you every step.
Everyone, we're back with another episode. I'm one from Nashville Fertility Center, my co-host and my friends from Texas Fertility Center, and Dr. Carrie Bedient from the Vegas. How are you guys doing?
How are you, Abby?
Fabulous. As before we sing. And so I hear this a lot for Halloween.
We decorated a little bit for house this last year, and things for these fantastic pumpkins that are they're about 2.5 feet long. So yeah, they're really cool. Grocery store is crazy. It's one of those all that stuff out front. So easy and lasting, like a symbol or things like that. But go put up in the attic when I like decorations that can kind of change. So, if I can cover Thanksgiving together at our house for Halloween, and so we sit out where a little bit. So I don't walk from house to house, like truck beds like that. And there's groups of kids that will, and so and my aunt and my cousin, and sometimes we have some other people. We all have our little chairs with our, we drink wine the evening, and kids come a house worth of candy. My house essentially comes. So it's kids get a good, so Carrie,
really love Halloween.
Surprised about that.
I think is the holiday that any other holiday. I think I saw that rule since I don't really do much, but.
And in it, since we moved to Los Angeles, I had a front yard, of course, in residency and fellowship, and little shoe boxes. Now that I have a front yard, I have tombstones. And so I have all these tombstones. I take the generation that you get and I strip off this, and then I take them. Now I have better saw tools.
How many have you built during your?
I've got 6, but they're I've got a couple doubles. I've got some have crosses shaped of. Most of them are just. I have the Wicked Witch with the striped. I have Dracula, different death dates. I have some rings all around them because I have to go around the neighborhood collecting my. Every year I secure them to work, and so I've got a full graveyard. Spiders that go all over every year I try and still thinking about what I need to do. I tombstones because they need a new coat of, but that buy a new thing of more tombstones too.
Really decorate for Halloween. It's not that cool to do that, but it seems like just before you know it, it's time to Christmas. And so Thanksgiving. But as you guys were talking, it made me think about Halloweens that I had was when I was in high at the time. We had about 200 people. We would do this haunted house every band. And now that I think about it, and anyway, I was the room that you were assigned to. Room and way to scare. It was pretty simple. It was literally another person laying in a casket was shut, and when the casket, of course, everybody's anticipating something slowly comes open, and then strobe light starts, and then you reach, and so oh my gosh, it's hilarious because people but they would just scream. That was one of the funnest, screaming. So that Halloween experience.
That is so cool.
Maybe that's what I need to add to the.
That's what you need.
Your phone.
Good.
Ask it, and then have not as but you could have that tiny stuff and then have one of those little fog and maybe you could move the top of the case
when someone's coming by.
Well, I hate to break up our funnest question of the day so the question of the day is that seems to never being pregnant or staying pregnant from a physician perspective.
Oh gosh, I was patients, it's hard going process of trying to conceive, not being able to, or is kind of one of those little, and you never, what if I can, you think about when it's one of those things that happen. And so I think come in with important to, you're in the state of mind is having, whether it's your girlfriend, a support online, or whatever you need somebody that you're not alone in this, and that really good treatment and some of it is what you personally are willing. Any of us can't pregnancy and a baby, but personal limits are thing way of those, and finding some comfort in doing. And like I said, you do have somebody to in and go through this journey.
So as a physician, there's definitely patients there. You're just, it's just one thing. You look at some of your other patients who just, sometimes it's hard to remember that you do have patients. They're not the ones that you were like the people who say because they on relatively quickly who I'm okay, this didn't work. Let's try this. And you're being a nation of supportive and real coach and these different roles and in positions really with more with in an infertility experience. You don't really get to as you don't know them. You see them really do feel like you know them because your chart and your whole their mind like where you're just going, oh my God, I have a baby so badly. And as the physician, I feel like as they look at me as before and I'm like, yeah, I've seen each through but it is very rare that I see in person like you are getting. But it happens forward. What about you, Abby?
For some patients to talk to, I think sometimes when some people have really supportive spouse, sometimes it just becomes overwhelming for both you and your spouse. And I think it's good to have sort of a neutral person to lean. It's really encourage others that are an issue party to really kind of, I've been there. It's hard to just keep looking on the bright things, just keep happening there. I think persistence pay to say, but I do find that somebody negotiate, eventually things, it's just really hard right when you're, the light at the end of the tunnel. This is the key. So I hate to sing, but I think probably need to move on to our topic of we're going to talk about recurrent pregnancy law. From a listener questions about recurrent pregnancy law. Gosh, we just need to talk about this. Why don't we start out, give us sort of your loss and kind of start.
Yeah, current pregnancy loss is pretty 2 or more pregnancy loss, then it warrants evaluation to change. Used to, we didn't work out pregnancy losses that somebody had at least 3 consecutive. I think that definition actually for patients and the betterment of, we've all seen this, who've had biochemical losses, very definitive way to be able to move people.
So Susan, what do you think about that? I think we have to have 2 documented. What having 2 that we just determined?
It depends on where you look up. And 2, I think that part probably when pregnant, very good. Like we need to see a baby. Whereas if and they've only had, they haven't had any document. I might quite as extent, but if somebody's had a pregnancy loss, I do biochemical pregnancy. It's one of those things that who are kind of mission. I've seen so many people that they're help.
Yeah, I think the only insurance company, sometimes there's not so much physicians. What are you
going to bring that up? When I talked to my look after age, no, that's a big group of people that affects. And we'll to say that could go after 2, then I think to it. Where we start is really and truly with the insurance to cover it. It happens to be some of it has enough where sometimes we can get it covered for infertility, but you can look at some of the structure, not some of the more genetic reasons. And often it's the biochemical and it's the definitions that ultimately, because after looking, but thousands and thousands of dollars, 3, then 1. And so I'll tell them that this is what we're looking for
a workup.
So evaluation, the structural component, there's genetic component. That's pretty straightforward, that ultrasound. You want to have some component to the vaginal ultrasound evaluation, I should say, whether 3D evaluation, endoscopy, or saline, salt water inside the ultrasound, looking at does any abnormality high on the list of things that can you want to know where there's horns or 2 angles to the uterus, kind of cohesive, a unicorn uterus or like a banana instead, so there's less space to grow. Now those tend to up in later pregnancy losses, evaluation for those types of things. Fibroids that are cavity, because that's the thing to find actually make a big difference. Polyp or fibroid. So if you've got a polyp or big fibroid, the growth of the endometrium or the fibroid is essentially the layer of the uterus and the cavity. And so this big, nice ovario to just stroll into and set up shop for 9 months, you have in the way. And cannot get its soft blankets and pillows all around. It's sitting there on a screw this, I'm going home, and it doesn't implant because it's comfortable for pregnancy to grow and a good place for the embryo to latch and stick on. In part, it's where it just can't
I usually say too, it's almost causes kind of irritation kind of as well. So yeah, it's identify those. Susan.
The other things I would look at, I typically do an HSG. The tubes are not a none because we know at least probably one of it, but we want to make hydrosalpinx, which is that fallopian tube can actually go back and hurt a developing pregnancy. Then from there, I take some blood tests. It's important to get on both partners.
What's a chromosome?
Kind of your genetic tests in the woman's skin, what the man is going to the baby making material. It's important for us and have all the, so sometimes in recurrent pregnancy have the right numbers of, but sometimes pieces are hanging out with another side down or different, and hormones like prolactin is kind of the metabolism, but it's very successful baby making, and is a hormone produced by your breast milk after off that can interfere with. And then I cut a panel of labs, anti-phospholipids, a mouthful, LS for short, and acquired blood clotting. And it's usually a confirmed test. Interesting thing about that test, and this actually goes a little bit for, we don't usually decisions based on, 12 or 13 different tests. There's a good chance that one of them did. So for the APLS, what we do is you have to wait between the initial test and the next. We see that next test, then we know that you're probably benefit from getting some in pregnancy to miscarriage.
You do tests for clotting disorders?
Don't typically do clotting disorders, second or third trimester, family history. I know that can practice.
So that's definitely something that I don't think the American College of Vet, I will say I do it a lot. How about you, Carrie?
Do it. Inclined to do it with a family. I will still, anything seems, because if you find it, you can do it.
And there's a pretty good study that clotting disorders like things like don't make a difference. It's hard to tell a patient that you have this clotting disorder, but I sort of chalk it up. I know about reproduction that was something, whether it be just baby situations, limited situations, Ovanox, if it was a patient that miscarriages. And so that's will do, and some physicians want that you would do, Carrie, that.
No, I think let's get the FSH levels, local count, just because if I find particularly abnormal, put more creativity leading to loss, same with sperm, abnormal, and maybe that's got to barely do as much about it. But
one thing that I usually do, and this one thing that is my evaluation for essentially the same evaluation is to see me for infertility, put it on. Do carrier screening. We see screening. You are going to get mutation testing. Even people maybe pre-mutation carrier problems getting pregnant. And so the big picture, and then.
So a lot of them end up doing all those. Honestly, a lot of them come anything. And so about half of them. And so because it feels like a lot that I can tell them. And so patients that had a completely normal loss in terms.
So heart will depend on seeing getting pregnant. Loss, have a event and it's staying pregnant. Some women have a difficulty in staying pregnant. So fertility component in there, you get pregnant and then from there. For the women, easily, and it's just the difficulties. There's two approaches, just the straight TLC. This is the economical and much more challenging. And if you get pregnant on your own way on progesterone, baby aspirin for a little, and essentially much more communication of coming and getting level they would if they just went to their now. All of those somewhat questionable. The data is there and it's not there depending on. So
I think TLC.
Nobody is extra loving, and sometimes the thing that I can do for my patients, but really it's extra holding because in most cases, nothing we can do to stop it. Checking their progesterone levels, making and giving them supplementation, the thought that it can not only later in pregnancy, but if it may have a difference there. I have your duty anticoagulant, not a diagnosis. So things I don't start unless.
Are you aspirin and progesterone, physician to physician?
I don't think they do any other.
Is either having trouble getting pregnant.
So I think it's important that we know that those are due to chromosome of the embryo, which normal dad's chromosomes are normal and sperm come together. There's abnormality in half of the embryos they create. I think we have these chromosomally implanting than they do in the average person. Often leads to those. You can have those. We can keep doing it like Carrie. We can do kind of ease like letrozole medications with insemination to kind of and do progesterone. So things aren't helping the chromosome. And I think a lot of the decision of how aggressive is that I have personally had patients who've had like miscarriages and went on, which the data trying most people with recurrent be successful. Now, with most people out there, kind of their hearts cannot. I just don't think for people who and that supports and refutes this we've talked about today. As I do discuss with chromosomes, then at least we are we know that 96 plus chromosomally normal. I mean, I can say personally obsessed with that. Unfortunately, nothing we percent. It is to be discussed, and it's the
IVF is like you just said, percent of the reason why people miscarry. Putting a normal embryo, but if it is, then problem. And so, unfortunately, it's one of the for a while. If we don't hit, that may end up being.
I would like to make a comment because pregnancy loss who are thinking about, do you extremely abnormal embryos, exceptionally rarely fertile?
I would agree.
I mean, one person somebody who I wasn't pregnancy loss and that so like those embryos just stick in other people pregnant.
No, I think that pretty quickly. I mean, for some patients, and do what you can. For other, right to IVF with the some, but not all people. Then we keep going.
Good. Well, thanks, guys. I hope this nurse. And so to our audience, in next week for more, subscribe and leave us a review and iTunes.
You can also censored.com to schedule or submit specific you have about infertility on the podcast Anonymous, the doc segment. So don't hold in the better.
Keep sending in those questions.
Bye, y'all.
Bye.